The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you very much for joining us on this webinar. My name is Dwayne Schultes. I am the Managing Director of Vital Transformation. Today I'm joined by Professor Graeme Houston of the University of Dundee. Good afternoon, Graeme.
Good afternoon, everybody.
Yes.
Thanks for joining.
And today we'll be discussing our research project on the impact of whole body MRA on the cost of ischemic cardiovascular disease. This is a research project we ran at the University of Dundee from February roughly till May, delivering results quite recently. And there are a few tools available for you to interact with us. Obviously, we've had several dozen people register for this webinar today, so it would be impossible for us to open up the microphones. But you can, working with the tool that you see on your screen. This is a copy of a tool that you should see on the cover of your desktop. You can raise your hand if you want to flag something to us or ask a question directly to me, and then I can chat with you individually. If you're having trouble with your audio, you can switch between the sort of Skype settings. They use mic and speakers, which I imagine most of you are using. But we have provided 25 different dial-in codes internationally, which should be toll-free for you. So you can switch to the telephone if you're having issues with your bandwidth. And then if you want to ask a question just directly in the chat function, you can do so at the bottom of the page. There's a little question indicator there. You can type a question and that comes in on my desktop, and I'll certainly endeavor to answer the questions while Graeme's speaking or when we get a chance to do so. I'd like to thank the following organizations who funded our research project and made this possible. The first one was the NHS Tayside, which is Scottish, Tayside where Dundee is located, as well as the University of Dundee where Graeme is a professor. Thank you, Graeme. And the Chief Scientist Office of Scotland, and that's Professor Andrew Morris's office. And again, we'd like to thank Andrew for his support. The research team representing Vital Transformation was Dr. Daniel Gasol and myself. Daniel was the lead researcher on the project. And then from Ninewells Hospital at the University of Dundee, it was Stuart Suddy and Graeme Houston. And again, we'd like to thank everyone involved in this project, for which this project would not have been possible without their input. So what is whole body MRA? That is really the question. What is this new technology, and why is it so much better, or why does it provide such excellent outcomes compared to traditional MRA? Graeme, if Graeme could help us here. Graeme, you can walk us through the exact technology. You are an expert in this space, and it'd be very interesting to hear your opinions of what exactly you've been doing at Dundee. Thank you, Graeme.
Thanks very much indeed, Dwayne, and thanks to all who have called in again. I'd just like to share with you some exploratory work we've been doing in relation to whole body imaging in relation to my primary clinical area, which is cardiovascular disease. We've been looking at using both 1.5 Tesla and 3 Tesla MRI to stratify patients, or to stage patients, if you will, for cardiovascular disease as a whole. And we've moved to combine whole body MR angiographic acquisition from the top of the head down to the feet with a full cardiac assessment. So combined in one examination, which takes about 40 minutes to complete. Why would we want to do this? Really, the bottom line here is that atherosclerosis, as we recognize, is a major global health condition. However, it is a systemic disorder. It does affect the entire vascular tree, and while it may be more severe in one area, this may occur in an undisclosed or undetected form in other parts. And severe disease in one area is predictive of disease in another. I've had a particular interest in peripheral arterial disease, and we'll talk mainly about this in the context of this and the health economics assessment that Dwayne kindly did for us. But in our population, and there's been recorded in many parts of the world, people with peripheral arterial disease have a lot of disease elsewhere, which is undetected or may or may not be symptomatic. So around a third of patients who have peripheral arterial disease also have renal artery stenosis, or narrowing to the arterial blood supply to the kidneys. About a quarter to almost a half will have carotid arterial disease. Over a quarter will have had a myocardial infarction or heart attack, and 6% will have had an unrecognized heart attack, one that's happened in silence but has caused significant damage to the heart. Similarly, in other areas, for people who present with transient ischemic attacks or TIAs and stroke due to carotid stenosis, there is similar crosscut of disease presence elsewhere. For the focus of the work today, however, I'm going to talk mainly about peripheral arterial disease. We're not alone in looking at MRI in terms of whole body assessment for cardiovascular disease. Whole Body MRA is acquired in 2008 by Hansen and his group, did some excellent work early on demonstrating the value of whole body MRA in a patient population from Sweden who were 70 years old. And they had 306 patients in the group, and they demonstrated that a quantitative total atheroma score, which summated the different vascular territories in the bodies as acquired by a whole body MRA, correlated with the established risk factors for cardiovascular disease. And more recently this year, in atherosclerosis, presented data to indicate that the whole body atheroma score is an independent risk factor for major cardiovascular events over and above the established risk factors, and provides additional value over Framingham type risk factors used. Similarly, in 2009, Merck in a smaller study demonstrated whole body atheroma score was correlated with the presence of significant coronary arterial disease. So what have we been doing in our center? We have both a 1.5 and a 3 Tesla Siemens systems, and we've been using whole body angiography to investigate patients for around 4 or 5 years. In the Siemens system, it's quite a complicated procedure in terms of setup in relation to surface coils covering the whole body. In other vendors, they don't use such an overarching coil arrangement, but can have similar results. Here's a result of a patient having had a whole body MR angiogram presenting with leg arterial disease. And the image on the left just describes the fact that you have full body coverage from the top of the head to the ankles. And then as we magnify up, you can see the detail in the MR examination is really quite exquisite in terms of demonstrating the arterial disease that you can see around the iliac bifurcation up towards the kidneys and further down the legs. Here's a second case where there is very established arterial disease with blockage on the right and the left leg with evidence of established collateralization. So from the whole body MRA we get whole body assessment as well as a diagnostic study for the particular presenting area of peripheral arterial disease. With the combined cardiac assessment, which is done at the same time, we establish left ventricular quantitation in terms of function, stroke volumes, and all the standard parameters that makes cardiac MRI the gold standard of left ventricular quantitative assessment. We also use the enhancement with gadolinium to determine and detect scarring that we may see in the wall of the left ventricle as evidence of a detected or undetected previous myocardial infarction. So our work has really demonstrated that whole body cardiovascular stratification with imaging and MRI is certainly feasible to do a combined examination of whole body MRA and cardiac MRI. And it has the potential to demonstrate occult disease, myocardial infarction, and arterial disease in a wide variety of sites within the body. So we found this work quite interesting. In terms of how you might use whole body cardiovascular MRI in clinical practice, there is very much a priority of peripheral arterial disease from the WHO that perhaps Duane would reflect on. But if we run through the evidence of why you might want to look at whole body atheroma burden, we can see that particularly peripheral arterial disease is poorly treated generally. The awareness of cardiovascular risk, in other words, if people are more aware of widespread disease, can lead to better compliance with drug treatment. Peripheral arterial disease patients are grossly undertreated in terms of the risk factor relative to other vascular territory disease. We can see that statins are used in only 31% of patients, and similarly for other risk-reducing therapies. And indeed, 50% of peripheral arterial disease patients do have underlying cardiac disease in terms of left ventricular hypertrophy, which we know is a key indicator of cardiovascular events and poor outcome and can be treated directly. And lastly, silent myocardial ischemia could also lead to the use of beta blockers for risk factor management for cardiac disease. Our current investigation of patients with peripheral arterial disease tends to focus on peripheral arterial disease, and we only really look elsewhere in the body by way of Doppler ultrasound or angiography or CT when we have symptoms in that territory. But the point is there's widespread disease. So we're suggesting that whole body cardiovascular MRI, particularly in peripheral arterial disease, could be used as an alternative investigative pathway where we visualize the arterial supply to the leg and in addition arterial disease elsewhere in the body that may lead to further treatment. So if we went down this route, what I was particularly interested to look at in relation to working with Duane was to say if we do extend the visualization of cardiovascular system to include this whole body approach or stratification or likened to cancer, the staging of cardiovascular disease, what would the health economics impact be? And at this point I'll hand back to Duane to describe what he's done for us in relation to the health economics assessment. Thanks very much indeed.
Yeah, thank you very much, Graeme. And just to build on what you just said, what we've seen in previous research that vital transformation has done is that diagnostic stratification is a very powerful tool not only to increase efficiency but also to increase impact and reduce cost, which is why, from vital transformation side, Dr. Daniel Gasol and I were extremely interested in approaching this project, and we're very grateful for you allowing us to do so. And with regarding the WHO and their interest in peripheral arterial disease, the 2013 Priority Medicines Report of the WHO that was released in May outlines quite specifically that the #1 health problem in Europe is ischemic cardiovascular disease. So for our standpoint, this was an area that we found extremely interesting, and the opportunity to dig into this research with Graeme and the staff at Dundee was excellent and very enjoyable and quite an interesting challenge. So the research question that Daniel and I asked ourselves when we approached the project was, what advantages, if any, can WBMRA generate in the terms of patients with claudication and peripheral arterial disease? What is the actual economic benefit? What can we find? What sort of scalability and health economic impact can we derive? So what we found was Graeme had been working with a cohort of 50 patients that were followed very closely through the radiological department of Dundee University's hospital. And Graeme, maybe you could dig in a little bit with us how those patients were selected. Why did you choose that 50-patient cohort?
Sure. These were patients who were referred to us for diagnostic imaging who had established peripheral arterial disease clinically. Basically, we used them as a cohort to test out the whole body MRA technique on the back of the diagnostic examination. Interestingly, they were all of a certain symptomatic type. They tended to be, as we would call, Fontaine 2B classification, so they were groups of patients who would generally walk between 50 and 100 yards before they had symptoms of poor blood supply to the legs.
So essentially we had a cohort that had exhibited similar states of condition, and then you had tracked them for 4 years with all of the procedures you had done, MRA, CT, angioplasty, angiogram, etc. That's essentially what we were presented with, correct?
That's right, yeah.
Yeah. So we were given this data set which had all of the clinical procedures for which we were able to follow each individual patient of the cohort for this period of four years over a treatment path. Now, one thing that we did not have was the surgical history or the outcome history. So really what we were looking at was strictly, in this case, in this examination, our research scope was limited to the particular areas of treatment related to the radiological procedure and the diagnostics, as well as the, shall we say, the outcomes, the prognostication, as it were. Now, the methodology, what we like to do in these sort of situations, and we did, is we built a model based on the current clinical practice. So this was the model that currently exists, and then in conjunction with that, once we had built the model that we feel represents well the current clinical practice, we then build a second model inserting the whole body MRA as an alternative procedure and measure the impact between the two models. We consulted literature and internal discussions with many of the staff at Dundee University. We were able to obtain quite a robust data set of actual costs from NHS Tayside's accounting, as well as insurance schemes of WPA and Bupa, which fund healthcare in the UK. So we were able to get an accurate look at what the actual cost structures were for these procedures. So then we were able to, in the course of the whole body MRA procedure, anticipate and measure the clinical impact through the entire process. And again, what we were looking at here are pre-existing cases of PAD. We weren't able to, or we're not interested in looking at potential cases or other cases that could be coming down the road. So this is not prevention per se, this is just measuring what's in the pipeline. The prevention side will be coming later, we hope. So what we found from the claudican patients is that they essentially lived in two distinct populations. 25% of the populations were quote-unquote short stay, which was under a year. So these are patients who came into the pipe very quickly and left. And then there were long stay patients, which were between 3.5 and 4 years, where the vast majority of the patients lived. Now Graeme, how would you typify clinically the difference between these two patients? Is it complexity of diagnosis? Is it state of disease? What's your feeling on this?
I think there's probably 2 points here. I think the first point is the people who we termed kind of short stay were people who came in with suspected arterial disease of a fairly mild to moderate type, had the treatment by way of intervention of risk factor modification, exercise programs, or interventions with vascular surgery or endovascular techniques as angioplasty and stenting. And they basically had that treatment and went away much improved. The people who tend to stay with us longer time are the people who have comorbidity with other cardiovascular disease issues, particularly in terms of cardiac disease, stroke, aortic aneurysm disease, kidney failure, etc. And also the group who the initial treatment for their claudication doesn't work. And obviously remain with us for further intervention.
Thank you.
The second group is particularly more complicated disease in terms of comorbidity elsewhere and failure of the initial intervention.
Yes, and what we found when we looked at this, as you can see, the chain of time. So essentially, 25% stay less than 2 years, 75% stay more than 2 years, and some of those even go beyond 5 years. But you can see where the 4-year was sort of the boundary, so 95% of those 75% stay for 4 years, so it becomes quite complex. And as we found, this is the hypothetical value chain that we developed. And as you can see, this is the process that occurs. So you have an ABPI test, basically a pressure test that occurs, and all the patients have that, and then you have 8% in the next step get a CT and 100% get MRA. And then beyond that, we have 62% have no examination. Those would be sort of the short stay patients who've had 1 or 2 claudication exams, etc. Then you have angiogram, CT, and MRA, and you can see the percentages of the patients that have those procedures. And then if they go beyond that, 30% of those then have angioplasty, and then there's surgery for 5%. I should add that the surgery data is averaged data because unfortunately we were unable to obtain the actual percentages of this cohort. We know the overall percentages of people who receive surgery, but we don't know this specific data set from this cohort in surgery. So we used the overall assumed data set from general practices in Scotland. So this is why those numbers are in red. Now what we find in the long stay patient group, and I'll flip back and forth here, is you can see the primary changes are in the amount of CT and angioplasty. You see we go from 0 of CT in the short stay patients, and we go up to 28% of those patients requiring CT. And you also see that half of the patients then who go through to further procedures have angioplasty, whereas only 30% have angioplasty in the short stay. So again, we're seeing a 20% increase in angioplasty and basically a 0 to 28% increase in CT scans. Now, what does this mean? What this means is you have a larger driver of cost, obviously because of the comorbidities that Graeme has described, and that drives a lot of the patient cost as we see it going through in the diagnostic process. So this slide is an overall examination and investigation of the costs that we see for all the basic interventions, whether it's short stay or long stay. And then what we can see is the hospitalization cost and the average cost per patient, as well as the consultation costs. This was our calculation cost based on the clinical pipeline that we had delivered and derived in the previous 2 slides. So here we see the total cost basis between short stay patients and long stay patients. And as you can see, the primary cost drivers are the radiological diagnostics and interventions. In fact, later I'll get ahead of this, but we found that 55% of all costs in the treatment and diagnosis of cardiovascular disease actually live in the radiological process. So the ability to streamline that process actually is an inflection point where you can drive a lot of efficiency. And I would assume, Graeme, that this was why you wanted us to look at this, because the assumption was, the hypothesis was, that whole body MRA should have been able to cut some of those costs, correct?
Yes, that's right. When you look at the patient individual records in terms of what they've been through for imaging, you find they've had a number of different investigations at different times. And the smoothing and simplification of that process certainly has the potential to be done by whole body CVMR.
Thank you. So what did we find? By running the whole body MRA process and working with Graeme and Stuart's study, we were able to determine areas of key intervention where whole body MRA could create efficiencies. So where we found this was in the CT scan area in the initial diagnostic phase after the ABPI, as well as the secondary treatment area of MRA, CT, and angiograms. As well, that's what these red boxes and circles indicate. We felt we could also cut the consultation period, so from going from 1 or 2 or 3 or 4 total consultations in this case, by the time you get to this third layer of consultation periods and diagnostic steps, we felt we could cut 1 or 2 consultations out as well. And so by working with Graeme's team and looking at the clinical impact of whole body MRA, we were able to make some determinations of impact. And what we see here are the actual reductions that could occur. And you can see we go from 15 cases of CT minus 11 for CT with other cardiovascular disease and CT specifically for peripheral arterial disease. We actually zero that out. We feel that whole body MRA, and again this is in consultation with Graeme and Stuart, we felt that this would actually zero out and those procedures would not be necessary. But you can see for MRA that of the 65 cases that presented, or 65 I should say incidences of the utilization of MRA, we found that we could reduce 15 of those, so roughly a 23% reduction. And then in the course of angiograms, we found that angiogram alone, or angiography alone, that was required primarily as a diagnostic, could be removed. So again, a 26% decrease in the utilization of angiograms, again with the relevant cost reductions. So what do we see? Again, averaging the total cost curves over the entire population, these are not specific costs, these are average costs over the populations depending on which procedures were utilized. We see the highest amount of impact in the cohort for the combination of MRA and CT and angiography. And what you can see there is 42% of the cohort is impacted with quite a large reduction in cost, roughly 10, well, close to 10%, about 8%. So what we see is as we expand this out larger, if we extrapolate this data for all of Scotland, you can see the amount of cases on an annualized basis that this would actually impact. And so the numbers start getting quite interesting for whole body MRA. And what we find then is if we look at the 13 million pounds spend per annum, if we look at the 42% of the patients at the upper end who could be impacted, that's over £1 million savings for nearly half of the cohort, which is quite extraordinary for basically a procedure that most hospitals already have access to or could have access to with limited investment or spend. And so what we see is the cost per PAD per annum, if we're dealing with diabetes then, knowing that the incidence of diabetes is an excellent pre-indication of peripheral arterial disease, again we see enormous impact and potential savings if this is scaled up and extrapolated across the entire UK. Getting close to £1 billion, which is really quite extraordinary. So what we see in Scotland, again, looking at PAD in general, with the use of whole body MRA are excellent potential savings long term. And I should also add that not only do these savings occur specifically for PAD, but it's also occurring because we're relieving internal pressures and utilizing resources more efficiently within the hospital by cutting consultations, cutting other practices that in essence become duplications. And again, if we extrapolate this up to the UK, you can see that the numbers become quite large. So what are our conclusions? We know that 75% of PAD patients require long-term or long stay. They have 50% higher cost. They will require angioplasty about half of the time. About a third are examined with CT, and 40% require multiple diagnostics. We also know that 55% of PAD hospital costs are for radiological procedures, and again, we can impact those with whole body MRA. And we also find that roughly, give or take, 8% of savings are possible by implementing MRA. So we find that the total cost per annum of treating PAD is roughly 13 million and 80 million in Scotland and roughly $1 billion in the UK. The optimization use of whole body MRA for PAD can be extremely beneficial, and we do advocate that this should be rolled out. We find that whole body MRA can save between 6 and 20 million pounds. Again, that's depending on which cohort is touched, which part of the cohort and the amount of procedures. That's not saying that we're not weaseling around in the data. We're just saying depending on how many procedures you've had, at the upper end, those patients, the 42% of the cohort that's required all of those data touches and all of those diagnostic procedures, that's where you see the 20 million pound savings. So that's roughly 20 million pounds and 42% of the patients who go through the clinical pipeline. And then we find that whole body MRA can reduce the utilization rates of MRI by about a quarter, and angiograms also by a quarter. So again, relieving pressures on the system. So the outcomes of this research, again, we were quite shocked, and pleasantly so, with the impact of whole body MRA potentially. And we were very pleased with the research outcomes, and we've also very grateful that Health Policy and Technology has agreed to publish those results, and that'll be released in December. We find that whole body MRA has the potential for improving the detection of latent PAD in patients with inconclusive ABPI tests. Now, Graeme, if you can just extrapolate on that, we find that there's currently right now in clinical practice there's a gray area in ABPI. So essentially there's an area where it's not quite sure what the next steps from a prognosis should be. Can you just extrapolate a little bit on that and explain?
Yes, the clinical assessment of patients with potential suspected peripheral arterial disease is clinical examination of pedal pulses and pulses in the lower limbs, followed with ankle brachial pressure indices, which is basically a pressure measurement at the ankle relative to the arm, which is indicative of underlying arterial disease. But both the clinical examination and the ABPI is not an exact science in terms of being able to discriminate really clearly patients with mild, moderate, or severe disease, particularly true in patients who have diabetes or patients where the vessels are very heavily calcified. So we do think that the earlier use of diagnostic imaging in selected patients may well lead to a greater level of improved diagnosis and stratification than just on the clinical basis alone.
Right, and what we hope to do going forward then is, and in fact we will be launching, we hope, with the finalization of the grant that we will be presenting on the 26th of September for Stratified Medicine Scotland, an exemplar grant to fund a clinical trial investigating the use of whole body MRA in those situations where the ABPI tests are inconclusive. So we hope to dig into that space where there could be latent PAD or latent critical ischemic cardiovascular disease that's currently going undetected, and see how whole body MRA can act as a preventative measure. And again, I think this is quite exciting, and we hope that the outcomes of this review are positive. Obviously, we're a finalist, and again, thank you, Graeme, for your help with that, and I think it's very exciting. And we look forward to seeing how this potentially could become not only an efficiency tool for treatment, but also potentially a prevention tool for what has been identified as previously mentioned by the WHO, the core area and problem for Europe, which is ischemic cardiovascular disease. So we think this potentially could be one of the first research areas looking at this as a preventative measure, which is extremely exciting. So Graeme, before we close or have any questions, what do you see going forward are some of the challenges of implementing whole body MRA? I mean, are there any barriers to implementing this, or is it a tool right now that's widely available and it's just a matter of changing clinical procedure and paradigms?
Yes, thanks. On a practical basis, the actual technique of doing it is widely applicable to standard clinical MRI units of all vendors. It can be done. Some of it will require some training and expertise development in local sites to do it, particularly if you're going to take on the cardiac assessment in addition to the whole body MRA work. But basically this functionality is available on all standard systems. So it's not like you have to buy a separate machine to do it. In terms of implementing it, beyond the training aspects, it's really a lot of clinical implementation relates to difficulties in adoption or barriers to adoption. And clearly we would have to work against a feeling of, if you like, a resistance to change agenda. So we have to think a little bit about how we move forward the knowledge base in relation to the value of these emerging imaging techniques. I think the cost effectiveness evaluation that Dwayne's done for us has basically indicated for me certainly that complex patient pathways can be evaluated with health economics assessment and can give you, even on relatively small cohorts, indicative directions of health economic benefits that in larger application or more widespread adoption can be shown to be a little more concrete. So I think in summary it can be adopted technically. It will require more evaluation and evidence for the value, and I think the evidence in terms of the value for patients will come if the alteration in the pathway leads to improved outcomes for patients.
Yes, and that's what we hope to dig in more with the grant that we assume and hope, fingers crossed, that we'll get at the end of next month. One other thing we discussed in the course of setting up this research project was the use of CT versus whole body MRA. Can you give us just some data or background on the difference in radiation dose, etc., between CT and whole body MRA and the potential benefit of whole body MRA, not only from a expedience and efficiency standpoint, but also from a patient perspective?
Sure. In relation to the radiation risks, clearly that relates to CT and doesn't relate to MRI because there is no ionizing radiation risk from MRI angiography. The issues are also of contrast administration, and the risks of contrast administration for CT angiography are actually generally higher than for MRI angiography. So from the risk side, the balance of support is really for MRI. The issue often comes down to the practicalities of what centres are doing in relation to what they have available and expertise for, and many centres in Europe are using CT as their primary modality for diagnostic imaging, particularly in claudicants rather than more severely ischemic legs. So it is obviously there are differences in practice. The question will be asked, could you do a whole body CT examination to get the same information? And certainly it's possible to do so, but one would have to be mindful of using this technique of CT due to the radiation exposure if you are considering doing it particularly for aspects of preventative medicine.
Excellent. Well, we haven't had any questions from our people reaching out who are with us today. If there are any questions, we'll take them now via chat. And just, Graeme, I do have one more question. How have you seen the application of whole body MRA grow in the UK? Are you seeing it being used more? Do you see this being picked up? Obviously, you're very active in promoting its use, and you're working very closely with several providers and developers of the technology. How are you seeing its current impact on, obviously you're a thought leader, how are you seeing this move into clinical practice now?
I think it's low level at this moment in time in terms of awareness and appreciation of the potential advantages of it. So I think we're at an early stage, but there is a growing interest in people who are asking us how we do it and how they could perhaps introduce it in their centre. I think the value will come and the real shift will come when you demonstrate the clinical outcomes benefits, which we obviously hope to describe.
We have had a question about the cost and how we determined the actual cost of the MRA. The cost of the MRA was determined by basically time, because an MRA takes 20 minutes longer, or whole body MRA takes 20 minutes longer than a standard MRA. And then we based the cost as well on the BUPA and basically the BUPA insurance guidelines for what the hospitals can charge. So essentially it was a two-tiered equation for us in the course of building the model, where it was an efficiency gain of time, a certain percentage, as well as the actual raw cost of the procedure. So I hope that answers your question. Graeme, I'd like to thank you very much for your time, and I'd like to thank everyone for participating. We will be creating a recording of this, and we will be mounting it on the Vital Transformation website, and we will be sending that out as we proceed going forward. We have another question here, and this is from a Robert Davey. And could you comment on how the cost of interpreting the MRI imaging, oh, sorry, we've answered that, forgive me. This seems to be the acquisition, not the interpretation. Thank you. It's, in fact, what we were looking at was the consultations as well. So what we find, Robert, is that with the MRA whole body, you not only cost the acquisition, but we also costed the clinical time. And what we found is by providing, and a lot of this information came from Stuart Suttie on the cardiovascular surgery side, what we find is that there's an enormous reduction in overall costs, not just from the procedural perspective, but also in the amount of efficiency that we can gain across all the treatment areas. And Graeme, if you could extrapolate on that a little bit, when we were discussing the comorbidities and the ability to identify what you call cycling, how you see whole body MRA impacting that. If you could just develop that a little bit, Graeme.
Sure. I think certainly in discussing through with our consultant vascular surgical colleagues, one of their biggest issues they have now is the patients who come in who are older, who are perhaps diabetic, and they come in with multiple comorbidities, and they come in with real leg arterial disease, and that's threatening their limbs. And the issue they've really got is how they can quickly get the information about comorbid risk in patients before they submit them to operations of vascular reconstruction or even amputation. So that by knowing that fairly early on the patient has got established carotid disease or cardiac disease or other disease elsewhere, other than what they would normally just be acquiring with the leg investigational study, does offer them a unique ability to move things fairly quickly through the diagnostic pathway, reduce the number of days in hospital, and potentially get patients through at a lower risk of intervention.
Thank you. So to answer Robert's question again, it's not just the acquisition is faster, it's also the procedural costs that we've identified using the BUPA pricing, the insurance pricing. We're able to then determine the amount of costs and the impact that it has on the entire health delivery value chain. And that includes the consultation period after the results are in. You're able to cut several consultations out as well. So we're saving Graeme's time, we're saving Stuart's time, as well as we're cutting out CTs and other unnecessary procedures. So I think that works. It seems to work very well. I think logically it's intuitive. It'll be interesting to see how it works when we scale it up, Graeme, I guess.
Absolutely.
Fundamentally.
Yeah.
Again, I'd like to thank everyone's participation today. It's been very enjoyable to talk about this project. It's been a difficult project, but an enjoyable one. It's always a challenge going into a new situation. And Graeme, I'd like to thank you for the collaboration on behalf of myself and Daniel Gasol. It's been extremely enjoyable. And we hope to be doing a lot more in the next couple of years, depending on how the feedback comes at the end of the month. So thank you, Graeme.
Thanks very much indeed. Yeah.
Thank you. And thank everyone for joining. And again, we'll be sending out an email where you can pass this link around to colleagues who are unable to join or are interested in this. So thank you very much for participating. And with that, we say goodbye. Good afternoon, everyone.